Hello everyone. Now today we'll be discussing about the urinary incontinence. This is a high-yield topic. There will be a one question in your board. So although it is a very easy, but there will be a question, and so we need to understand it very clearly. Okay. So urinary incontinence, there are three types. There are three types mainly, but we can say stress incontinence, urge incontinence. There will be mixed incontinence as well, and overflow incontinence. Okay, the problem is that in stress incontinence there is outflow obstruction. Okay, so outflow obstruction is actually here in overflow incontinence. We are talking about stress incontinence. Stress incontinence is outflow incompetence. It means that there is a problem in outflow. There is incompetence in the outflow. Outflow is urethra and internal urethral or internal sphincter that is present in the bladder. Okay, so internal intrinsic sphincter, say you can say. So we are talking about the problem is outflow incompetence, and that is urethral hypermobility or intrinsic sphincteric deficiency. So these two regions are responsible for your stress incontinence. Actually, what is stress incontinence? Stress incontinence is incontinence of the urine, leak of the urine in presence of any intra-abdominal pressure. Okay, so if there is a coughing, your intra-abdominal pressure will be increased. Coughing, sneezing, lifting, this will increase your intra-abdominal pressure, and that when cause pressure of your bladder, then there will be leak of urine. Despite you are having any odds or anything, you are not having any odds for going urination, but it can be leaked, and it is leaked due to the urethral hypermobility or lack intrinsic sphincter deficiency. Okay, so this is stress incontinence. Simply any increase in intra-abdominal pressure or any leak of the urine due to coughing, sneezing, or say lifting, then that is stress incontinence. That is all. Okay, now we have to know one more thing, is that what are the risk factor for this stress incontinence. The risk factor for stress incontinence is obesity, vaginal delivery, prostate surgery. These are the risk factor for stress incontinence. Okay, now how we'll diagnose it? Simply you get a patient, say to cough in front of you, or when you see that any suppose coughing, sneezing, or any valsable maneuver you have proceeded, there will be the leak of urine from the urethra. That is bladder test positive. Okay, so diagnosis made. Now you need to treat. For treatment, we don't have any specific drug for managing of this urethral hypermobility, but there is a few exercise. Reduction of the risk factors, suppose like weight reduction, then pessaries application, and there is another exercise known as the Kegel exercise, that is pelvic floor muscle strengthening exercise. That is very important. That will increase the strength of your pelvic floor muscles. Okay, how will do the Kegel exercise? Simply you lie down on your back, fold your knee. Okay, you lie down on your back, fold your knee. Okay, and from here what you do is you try to hold the urination and defecation. Suppose you are going to urinate and you are holding with your pelvic, tightening the pelvic floor muscle is known as the Kegel exercise. How it will do? You just try to hold the urination and defecation likewise. Okay, so you try to hold your urination and defecation. There will be tightening of the muscle of your pelvic floor. You count for 1, 2, 3 and relax. Then you repeat this term for around 10 to 15 times at one setting, and it can be done into 3 times a day. So morning, afternoon and evening, 3 times per day you do this Kegel exercise in one setting, 10 to 15, and one is about 3 seconds. In this way, if you continue for a few days, you will have your strengthening of your muscle, and this will actually improve your symptoms. So hope you have understood Kegel exercise also, and about stress and incontinence as well. Okay, now we are talking about the urgency incontinence. Urgency incontinence means when urine gets into the bladder, it gets some volume, then it is stretched over the receptor, send the impulses to the nervous system, okay, to the spinal cord mainly. Then we will have urge to go for urination. But in this patient, like if we have the urge, we'll go to the restroom and do the urination. But in this patient, what happened, when the urge comes and if the bathroom is nearby also, then the time which is required for going to the bathroom in the way the urine will leak out, means he or she cannot be able to go to the bathroom, and before going to the bathroom the urine will leak out, and this is known as the urge incontinence. That is, leak with urge to void immediately. Urge comes and it's leak before it goes to the bathroom. That is urge incontinence. Why it has happened? It is happened due to overactivity of the bladder. Look, here is about, we are talking about urethra. Now we are here talking about the bladder. The bladder is overactivity, and if bladder is overactivity means bladder is contracting, and if bladder is contracting means when you have urge, it will contract more fast and urine will leak out. So overactivity of the bladder, that is detressor muscle instability. Okay, so you have to further go down and understand that smooth muscle are normally present in our bronchus, stomach, intestine, urinary bladder, and in case of female, uterus. These are the places where smooth muscle is present, and in smooth muscle you will find the muscarinic M3 receptor. Okay, if you know the sympathetic and parasympathetic system where we have arranged our muscles, then in smooth muscle M3 receptor is there. If we stimulate the M3 receptor, there will be contraction. So M3 receptor is stimulated highly, and there is detressor muscle contraction instability more high. Okay, so for that, what we can do, we can give the management, and management can be given by inhibiting this M3 receptor by a muscarinic antagonist, and that is oxybutyrate. So you have to understand, if you do the Uworld, then you will have one question, and the question will be like that: a patient came to you or came to doctor, and he or she was really embarrassed because of urine outflow before going to the bathroom. He tried the pelvic floor, he tried his some exercise, but there was no improvement. Then doctor gives some medication, and they will not ask you about what was the medication. They will give you on which receptor it will act. So it will be secondary or third degree for integration with your pharmacology as well. So you have to understand not only your case, not only your content, but also other integration with physiology, pharmacology, pathology, and that is the what question will be on the USMLE board. Okay, so if you understood, urge incontinence, leak up with urge to void immediately due to overactivity of bladder, that detressor muscle instability. Okay, now the problem is, what was the treatment? Treatment will be, one is again the pelvic floor muscle exercises. Okay, Kegel exercise, what I have explained earlier. You perform the Kegel exercise, there will be improvement. Okay, if doesn't improve with the Kegel exercise, then you have to go with the treatment, that is oxybutyrate. Okay, that will inhibit the M3 receptor and detressor muscle, that is smooth muscle of the detressor muscle, and inhibit the contraction. That is all. Okay, so mixed incontinence is feature of both this incontinence, that a patient will have the feature of a leak of the urine even with intra-abdominal pressure increase, coughing and sneezing. Now, with or if patient has urge, void immediately, leak immediately, that is also will be present there. Okay, so these are about the incontinence that will leak. Okay, now there is overflow incontinence. Overflow incontinence means that the bladder is less active, it need to be full, and after filling up it will leak out. Okay, I am again repeating it. Here is overflow incontinence, means incomplete emptying, the bladder detressor muscle under activity or obstruction. So if there is obstruction in your urethra, or you have a patient has elderly benign prostatic hyperplasia, there is an obstructive feature, obstruction is there of the urine outflow, or say there is any detressor muscle inactivity, so your bladder is not contracting, or even contracting, the obstruction, it is not passing the urine, so your bladder is getting filled up, and after a certain limit the urine will leak out. This is overflow. Okay, so there will be overflow, leak with overfilling. Okay, so there will be incomplete emptying, they have to tell you, and I have to explain you about detressor in underactivity or obstruction like benign prostatic hyperplasia. There will be leak with overfilling. How will you manage this? This will be managed again with the, what you will be finding over here. If you do an ultrasound, do a catheterization, then you will find that post residual volume, the urine inside the bladder, even after urination, there will be a significant amount, and that will be the classical finding of your overflow incontinence. Okay, management will be on our same side. Since there is obstruction, so suppose of benign prostatic hyperplasia, then BPS, then we can relieve the obstruction by alpha blocker. Okay, or even catheterization will help us. Even we will do the intermittent catheterization, then the urine will come out and patient will feel relief. Okay, so this will be the management of your overflow incontinence. Okay, now there will be another term which will be asked, and there is a question in Uworld if you go through it, that a patient was gone under surgery, and after post surgery the patient developed urinary retention. Now what we will do? And there will be a long question that patient was undergone any intra-abdominal surgery, then post-operative he is not passing the urine or he has the urinary retention. What will be the further management? And in that case, you again come to the receptor, M3 receptor. Since there is a smooth muscle, M3 receptor is there. Now we can give a drug. Here what we have done, there was an overactivity of that muscle, so we have tried to inhibit it, but retention is underactivity, and in that case we can give a agonist, muscarinic agonist, that will stimulate that smooth muscle and have the urination, that this may stimulate the bladder. And in that case, if there is a post-operative urine retention, in that case we can give bethanicol, that is M3 agonist, and that will help in activity, increase the stimulation, increase the activity of the detractor muscle and help to urinate. So I hope you understand the incontinence over here, and there is not much to think about. There is type, you will have a scenario, there is stress, urgency incontinence, mixed, usually not given, and there may be overflow incontinence, and sometimes you can give about the post-operative retention as well. So you should understand your content, then also understand the detail about the receptor, muscles and receptor, and apply accordingly, integrate accordingly, and you'll be able to answer your question.